Hi, I'm Caroline Newsome. I'm an attorney at Newsome Law. In this video, we'll be exploring feeding and nutrition in people living with locked-in syndrome, including the use of feeding tubes and gastrostomy dietary considerations, and how rehabilitation can help some individuals gain the ability to eat by mouth. Let's begin by unpacking the challenge that locked-in syndrome poses for eating and nutrition. Locked-in syndrome is caused by damage to the brainstem. Although individuals remain fully conscious and aware, paralysis can affect nearly all voluntary muscles, including those used for swallowing. Because of this, people who are at the beginning stages of locked-in syndrome will initially be fed through a feeding tube, since they are unable to safely eat or drink on their own. When the muscles that control the mouth and throat, called the oropharyngeal muscles, are weakened, food and liquids can enter the airway instead of the stomach, which can lead to pneumonia or choking. To prevent these complications, nutrition and hydration are delivered through feeding tubes until swallowing function can be evaluated, and in some cases, rehabilitated. In the early stages of recovery, patients are often given a nasogastric tube, or NG tube, which is inserted through the nose and into the stomach. This allows doctors to provide medications and test if the body can tolerate feeding tube formulas. While effective for short-term care, NG tubes can be uncomfortable and increase the risk of nasal irritation and infection. For long-term feeding, doctors typically recommend a gastrostomy, also known as a PEG tube. A gastrostomy is a small surgical opening made directly into the stomach, allowing food, water, and medications to be delivered through a tube in the abdomen. PEG tubes are more comfortable and sustainable than nasal tubes, and they can be used for months or years if needed. Caregivers are trained to manage feedings and flush the tube with water to prevent blockages. Caregivers will also keep the gastrostomy site clean by using soap and water to prevent infection. Most importantly, the feeding process can be done at home, giving families more comfort and control. Now that we have an understanding of the mechanics, let's discuss nutritional planning and creating a feeding schedule. Feeding can be given in two main ways: continuous and bolus feeding. Continuous feeding involves a pump that delivers formula slowly over several hours. This works best for those with slow digestion or poor tolerance to large volumes of food. In contrast, bolus feeding uses measured amounts of food given several times per day through a syringe or gravity bag. This mimics normal meal patterns, given 4 to 6 times per day. However, it is usually done through a PEG tube. People with feeding tubes should be sitting upright or with the head of the bed elevated during a feeding and for 1 to 2 hours afterwards. This reduces the risk of inhaling the formula into the lungs, and it allows gravity to help move the formula through the digestive tract. Nutrition plays a vital role in recovery and overall health for those with locked-in syndrome that experience paralysis. Health concerns impacted by diet like muscle loss, pressure sores, reduced bone density, and a weakened immune system are at the forefront. No two cases are exactly the same, so every nutrition plan needs to be personalized. Dietitians are a key component in properly creating customized feeding formulas for people with locked-in syndrome. These formulas are carefully designed to provide the right balance of calories, protein, fiber, vitamins, minerals, and fluids for each person's unique needs. Protein helps maintain lean body mass and lowers the risk of pressure injuries. Calcium-rich foods or supplements support strong bones and help maintain bone density. Antioxidants help reduce inflammation and strengthen the immune system. Fiber, along with prebiotics and probiotics, support gut health and keep the bowel system functioning well. And of course, staying hydrated is essential. not only for digestion, but for supporting all bodily functions and help prevent complications, like urinary tract infections. Speech and language pathologists, or SLPs for short, are also central for rehabilitation for locked-in syndrome. Along with speech, they are experts in swallowing therapy, known as dysphagia rehabilitation. An SLP will evaluate swallowing safety using a video fluoroscopic swallow study, or fiber optic endoscopic evaluation of swallowing. These tests show which muscles are working and which are weak or uncoordinated. If there is potential for improvement, the SLP will design a therapy plan that can include oral motor exercises to strengthen the lips, tongue, and jaw, thermal tactile stimulation, which helps trigger the swallowing reflex, positioning strategies to reduce choking risk, for example, chin tuck posture, and gradual texture advancement, starting with thickened liquids and pureed foods before progressing to soft or regular textures. The possibility of rehabilitation and progress toward oral feeding must also be considered. For individuals with incomplete or classic locked-in syndrome, gradual recovery of facial or throat muscle function may allow some return to partial oral intake. This process is slow and requires coordination between neurologists, dietitians, and speech therapists. The nutrition process for people with locked-in syndrome typically follows this timeline. First, tube feeding only until swallowing is deemed safe. Second, swallow trials, which involve small amounts of thickened liquids or purees under SLP supervision. Third, partial oral feeding, which combines small meals by mouth with supplemental tube feedings. And finally, the fourth, full oral feeding, which can only happen once nutrition and hydration can be safely maintained through eating alone. Even after successful transition to each step, many continue to work with therapists to keep up strength and coordination. Ongoing therapy helps maintain safe swallowing patterns and monitor for complications like pneumonia or weight loss. When oral feeding resumes after a successful transition, the diet often begins with pureed foods with smooth consistency and no chunks, thicken liquids to a slow swallowing and prevent inhaling liquid into the airway, soft foods like mashed potatoes, yogurt, or scrambled eggs, and finally, a gradual reintroduction of regular textured foods as muscle control improves. It is important to allow the patient to make decisions for themselves when determining a feeding method and a feeding schedule. Respecting a patient's preferences promotes dignity, trust, and emotional well-being, and it ensures that care aligns with their personal values and goals. Nutrition and feeding care are central to both medical treatment and patient rights. When feeding tubes are improperly managed or when swallowing assessments are delayed or ignored, patients can suffer avoidable complications like malnutrition or choking risk. It is important to note that family members of people with locked-in syndrome have the right to ask questions and expect quality standards of care at every single stage. If you or someone you know has been diagnosed with locked-in syndrome and have questions about medical care, rehabilitation, or legal rights, visit us at Newsome Law. We're here to help.